Good day, everyone. I'm Dr. Messina. Today, I will be discussing and dividing hematology into three topics, namely RBC disorders, white blood cell disorders, platelet, thrombosis, and hemostasis. Hopefully, you will remember these hematology concepts during your board exam. Let's start off with the most common RBC disorder, which is not only the problem of hematologists, but I'm sure more than once in your career as a physician, you will encounter this, and that is anemia. Anemia is defined as decrease in number of circulating red blood cells or a decrease in the level of hemoglobin and or hematocrit. The World Health Organization defines this as a hemoglobin level of less than 12 grams per deciliter in women and less than 13 grams per deciliter in men. Okay, let's go to some basics. The process of RBC production is called erythropoiesis and it occurs in the bone marrow. Erythron is the basic unit of the bone marrow, which are the precursors of red blood cells. Now, to make red blood cells, you will need erythropoietin, which is the regulatory hormone, interleukins, growth factors, and some cytokines. The main stimulation of erythropoiesis is hypoxia. All of this influence the production of red blood cells. Good day, everyone. I'm Dr. Messina. Today, I will be discussing and dividing hematology into three topics, namely RBC disorders, white blood cell disorders, platelet, thrombosis, and hemostasis. Erythropoiesis starts from the multipotential hematopoietic stem cells, which gives rise to the different blood lineages. So, this figure uh, will show you that the multipotential hematopoietic stem cells give rise to the red blood cells, the white blood cells or the granulocytes, and the platelets, which come from the myeloid precursors. And then on this side, you have the lymphoid precursors. An important immature form of red blood cell is the reticulocyte. It's a little bit bigger than the usual red blood cells, and it has no definite nucleus. They are called reticulocytes because of the reticular or mesh-like network of ribosomal RNA that becomes visible under the microscope with certain stains such as new methylene blue or Romanovsky stain. This is a peripheral blood smear wherein you can see the normal red blood cell. This is a higher magnification on your left side, and the right side you have a magnification, and then you have a segmenter, one segmenter here. Good day, everyone. I'm Doc. And what are the characteristics of a normal red blood cell? It has no nucleus. It has a biconcave disc shape with a one-third central pallor. Its energy comes from anaerobic metabolism using the Embden-Meyerhof pathway and hexose monophosphate shunt pathway. The lifespan is 120 days. The cytoplasm of an RBC consists of hemoglobin molecule, which is composed of four protein globin chains. So if you are asked what are the globin chains in an adult hemoglobin, the answer is two alpha globin chain and two beta globin chain. Each heme group consists of a porphyrin ring with an iron atom in the center. So look at the figure here that is color yellow. Now let's go clinical. Once you have a patient with anemia, a good history is tantamount. You have to elicit the onset of anemia. Usually, acute or sudden drop in hemoglobin is associated with symptoms and signs of hemodynamic instability. On physical examination, we have to look for the following signs in the skin, the mucosal membrane, the cardiovascular, and reticuloendothelial organs. So on the skin, you will look for pallor and some skin changes that may be the clue of the cause of anemia. And then mucosal ulcers may also be, and fissures may also be significant. The first system that compensate in patients with anemia is the cardiovascular system. And so pulse rate or cardiac rate is very important, and blood pressure. And then the reticuloendothelial organs such as the spleen, the liver, and the lymph nodes are also important. Since time immemorial, the screening tests for anemia have not changed. Fortunately, they are all readily available and inexpensive. So the first would be to confirm anemia, you have the routine complete blood count. The three basic measurements for anemia are red blood cell count, hemoglobin, and hematocrit, and these are the normal ranges. As a general rule, when the RBC count is multiplied by 3, it should approximate the hemoglobin. And when hemoglobin is multiplied by 3, it should approximate the hematocrit. And if not, it indicates the presence of microcytic or macrocytosis or hypochromia. And this is where your RBC indices can help you. So for example, in the following values in your slide, if the RBC count is 5 million, you multiply that by 3, then the hemoglobin is 15. And your hemoglobin when multiplied by 3, then the hematocrit is 45 or 0.45 or 45%. Now, there are times when the CBC results do not give the RBC indices. These measurements are very important in formulating the differential diagnosis. You can derive it by using the following formula. Your MCV consists of the hematocrit divided by the RBC count times 10, which is a constant. You'll get a value in femtoliters. Later on, you'll see how these indices can be used in the differential diagnosis. There are three causes of anemia. They can be classified into decrease in production of red blood cells. These are your hypoproliferative anemias or the failure of the bone marrow to produce red blood cells. Second, anemia may be caused by increased destruction of red blood cells, like in hemolysis, wherein there's decreased survival of red blood cells. And third, you have loss of red blood cells due to bleeding. Might it be an acute or chronic blood loss? Hypoproliferative anemias may be due to 1. Failure of RBC maturation, and 2. It may be due to a problem in the bone marrow per se, or the factory of the blood. So for failure of maturation, it may be due to a nuclear problem or a cytoplasmic problem. What are the nuclear breakdown disorders? This may be due to folate or B12 deficiency, because we know that they are important in DNA synthesis. Then we have the cytoplasmic breakdown disorders, which is due to a defect in the heme, like iron deficiency anemia and or sideroblastic anemia. And then we have the bone marrow failure syndromes such as aplastic anemia and myelodysplastic syndrome. The next diagnostic test after the complete blood count is the reticulocyte count. Reticulocytes are apprentice red blood cells or immature red blood cells. Again, they have fragments of nuclear material or ribosomal or RNA strands which stains blue. The normal value is 0.5% to 1.5%. You should not take the reticulocyte count as it is. We usually compute for the corrected reticulocyte count to know if the bone marrow is able to compensate adequately to the level of anemia. Because if indeed the bone marrow is normal, then we expect a high reticulocyte count in a patient who is anemic. The formula is shown in this slide. You need the reticulocyte count in percent, the hemoglobin of the patient and the normal hemoglobin or average normal hemoglobin, or also you can also use the hematocrit of the patient and the normal hematocrit. So for example, we have an anemic patient with a hemoglobin of 7.5 grams per deciliter and a reticulocyte count of 9%. We can compute for the RPI in several steps. First, we have to compute for the corrected reticulocyte count. This is by multiplying the reticulocyte count in percentage to the result uh, of dividing the hemoglobin of the patient, that's 7.5, divided by the average normal hemoglobin, which is 15, then you would get a corrected reticulocyte of 4.5%. And for you to get the RPI, you have to divide the 4.5% to a correction factor. And the constant that we use is 2. And so 4.5 divided by 2, you get an RPI of 2.25. So what does that 2.25 mean or imply? In this slide, you can see the use of computing the RPI. RPI can help you evaluate if anemia is due to bone marrow production problem or peripheral destruction or blood loss. So in our patient, it we have a high RPI, which is more than 2.25, then it is most likely due to um, peripheral destruction of red blood cells or blood loss because the bone marrow is compensating adequately. The next test that is important in anemia would be the RBC indices for us to know what is the RBC size. So it is seen in your mean corpuscular volume or MCV, while your MCH and MCHC talks about more of the degree of hemoglobinization of the red blood cells. This is the normal red blood cell size. It's 8 micrometer in length and 2 micrometer in width. So you can see the biconcave disc and the 1/3 central pallor. What's the use of the mean corpuscular volume? The normal value would be 80 to 100. So anything that is less than 80 would be called microcytic red blood cells or microcytic anemia. And if it's more than 100, we call it macrocytic anemia. And if it is within 80 to 100, these are the normocytic anemia. And this will help us in our differential diagnosis. In this slide, you'll see the use of MCV, and it will help us in our differential diagnosis. For microcytic anemia, the most common would be iron deficiency anemia and thalassemias, while other hemoglobinopathies, chronic infection, and sideroblastic anemias may also cause microcytic anemia. For macrocytic anemia, the most common would be megaloblastic anemias, and the non-megaloblastic anemias such as liver disease, um, metabolic disorders, marrow disorders would be the possible cause of macrocytosis. And then the most difficult of all would be the normocytic anemias because there are myriad of diseases that may cause normocytic normochronic anemia. Next, we have the RDW, or red cell distribution width. It's a measure of the range of variation of the red blood cell size and shape. So you say an isopoikilocytosis, or the red blood cells have different size and shape if their RDW is high. And the last basic test for anemia is the peripheral blood smear, or PBS. What are the information you can get from a PBS? It can tell you the size and shape of the red blood cells. Are they of the same size or shape? The color or hemoglobin saturation of the red blood cells. Okay. If there are RBC inclusion bodies or RBC hemoparasites, it can also tell you or describe the white blood cells and its distribution, and also the platelet distribution and morphology. This is an example of an anemic patient with microcytic hypochromic anemia. Coupled with a history of blood loss, either gastrointestinal or genitourinary blood loss, then the most likely diagnosis is iron deficiency anemia. This is a typical peripheral blood smear of a patient with severe microcytic hypochromic anemia. Look at the central pallor. It has a very wide central pallor, almost thin rim, okay, of hemoglobin or cytoplasm. So this is either an iron deficiency anemia or maybe thalassemia. This is another example of microcytic hypochromic anemia but in lower magnification. So as you can see, you have um, red blood cells that have very big central pallor. Okay? And you have smaller red blood cells, and we usually compare them to the size of the lymphocyte. So um, in the 6 o'clock position, you have two lymphocytes, and as you can see, the red blood cells are smaller than the lymphocytes, and so you call them microcytic red blood cells. So aside from the basic tests that I have enumerated, we discussed a while ago, no? The most important test to establish iron deficiency is serum ferritin. So you may use this as an algorithm. If the serum ferritin is less than 33 picomole per liter, then that is overt iron deficiency anemia. If it's more than 270, then it's not iron deficiency anemia. It may be due to other hemoglobinopathies like thalassemias. Now, sometimes you have values that are in the middle, then you have to compute your TSAT and look at your TIBC. If the TSAT is less than 30%, then that's iron deficiency anemia. How do you compute for your TSAT? You have to divide the serum iron divided by TIBC. Okay? Remember that the TIBC is inversely proportional to the serum ferritin or serum iron. So if you have high TIBC, then it's more compatible with iron deficiency anemia, because that means you have low iron, hence the binding capacity of your receptors would be higher. This is an important slide. It's a must known in your level, and this is the different stages of iron deficiency. So the first stage would be a negative iron balance, and as you can see, the one which is affected here, or you would note a decrease in iron stores, but the erythron iron, or iron that is in the bone marrow, would be relatively normal. That's why the some of the tests that I've mentioned a while ago would be normal, okay, except for the serum ferritin, which is less than 20, and then your TIBC, which is more than 250. And then the second stage would be an iron deficient erythropoiesis. And as you can see here, your iron stores are even lower, and the iron in the erythron or in the bone marrow is starting to also um, decrease. Now, even the iron in the peripheral cells will now be affected. Okay, so it is characterized by non-detectable bone marrow iron. You have a serum ferritin, which is less than 15, a higher TIBC, and then you have your low serum iron. The TSAT is also low, less than 20%. Okay, and you may have a normal RBC morphology. For overt iron deficiency anemia, then you have no iron, bone marrow iron stores. You have serum ferritin of less than 15, high TIBC of more than 400, serum iron less than 20, your serum TSAT is less than 10%, and now it exemplifies a microcytic and hypochromic anemia. These are some of the important pearls for iron deficiency anemia. Always look for occult blood loss. If the patient denies any bleeding, then you have to investigate for occult blood loss, and you may test that, okay, by requesting for fecal occult blood test or um, FIT or fecal immunohistochemical test. And then there are some symptoms, peculiar symptoms that may be seen in iron deficiency anemia, such as pica or phagophagia or eye sucking. Okay, the absorption of heme iron is higher in ferrous than in ferric state. And then absorption of iron can be decreased by the presence of food in the stomach, phytates, calcium, phosphates, and antacid, while the absorption is increased in the presence of ascorbic acid. The first line of treatment would still be oral iron therapy or oral iron supplementation. We reserve IV iron if oral iron therapy is not tolerated, while packed red cell transfusion is reserved for emergency cases. Now, the earliest response when you give oral iron supplementation would be an increase in reticulocyte count within 4 to 7 days and peaks at 1.5 weeks of oral iron or IV iron supplementation. And it's important to continue your iron supplementation at least 2 months after the normalization of your hemoglobin in order to build up the stored iron. So here in this table, I summarize the diseases or the disease states which can give you microcytic hypochromic anemia and the level of their serum ferritin and TIBC. So for iron deficiency anemia, you have low serum ferritin and high TIBC. For chronic infection, you have high ferritin because ferritin is an acute phase reactant, and you have low TIBC. For thalassemia, you have high ferritin. It can have a normal TIBC, and this is also seen in other hemoglobinopathies. For lead poisoning, both are normal. And for sideroblastic, you have high ferritin and normal TIBC. Good day, everyone. I'm Dr. Messina. Today, I will be discussing and dividing hematology into 3 topics, namely RBC disorders, white blood cell disorders, platelet, thrombosis, and hemostasis. Hopefully, you will remember these hematology concepts during your board exam. Let's start off with the most common RBC disorder, which is not only the problem of hematologists, but I'm sure more than once in your career as a physician, you will encounter this, and that is anemia. Anemia is defined as decrease in number of circulating red blood cells or a decrease in the level of hemoglobin and or hematocrit. The World Health Organization defines this as a hemoglobin level of less than 12 grams per deciliter in women and less than 13 grams per deciliter in men. Okay, let's go to some basics. Let's go to the macrocytic anemias. They are divided into megaloblastic anemia, which is caused by either folate or B12 deficiency. But there are times when these two are coexistent in one patient. Cobalamin, which can only be synthesized by bacteria, is present in animal products such as meat, poultry, and fish. And so B12 deficiency is more common, especially in elderly, those with decreased absorption, and chronic inflammatory state of the colon, such as Crohn's disease. While folate, it's more ubiquitous in the food that we eat, okay? So it will actually take a long time for it to develop in a patient. And so most commonly, these macrocytic and patients with macrocytic anemia would be asymptomatic unless the hemoglobin is less than say 70 grams 7 grams per deciliter. Okay? These are the causes of non-megaloblastic macrocytic anemia. The most common would be alcoholic disease, liver disease, metabolic diseases or disorders such as hypothyroidism, myelodysplastic syndrome, bone marrow infiltration, when there's accelerated erythropoiesis, especially in hemolysis or RBC destruction. There are also drugs that can cause macrocytic anemia, such as chemotherapy drugs or cytotoxic drugs and immunosuppressive drugs. So again, as I mentioned earlier, these patients are usually asymptomatic because it's chronic and a slow decrease in hemoglobin, and so the cardiovascular system is able to compensate. If you see an MCV of more than 110 femtoliters, almost always it is caused by megaloblastic anemia, that is folate or B12. So this is an example of a patient who is anemic with a hemoglobin of 10.6, hematocrit of 0.31, and as you can see, the MCV and MCH is very high. This is a megaloblastic anemia. So on peripheral blood smear, you can see these big red blood cells here. Okay, they are varying in size, and then you can see a segmenter here with a lot of nuclear lobes or nuclear segments. So you call it a hypersegmented neutrophil, which is seen in vitamin B12 or folic acid deficiency. This is another example of hypersegmented neutrophils. You have 1, 2, 3, 4, 5, 6, 7, 8 segments, and usually the normal would be 3 to 5 only. So for the physical examination of patients with megaloblastic anemia, which are severe and long-standing, would be check the tongue of the patient. You would see that this is bald, smooth, and lemon yellowish red in color, and usually they would feel a tingling sensation in the lips, in the tongue, in the tip of the tongue, and also the fingertips. So the treatment of megaloblastic anemia would be to supplement the deficient vitamins. So if it's a cobalamin or B12 deficiency, you can use cyanocobalamin 1000 micrograms once a day or methylcobalamin. And if it's folic acid deficiency, you can use folic acid 5 milligrams to 15 milligrams once daily. Okay, let's go now to the normocytic normochromic anemias. And these are the common diseases and are actually the most difficult to work up. Okay, and look for the possible cause of this anemia, because there are a lot of diseases that can cause these normocytic normochromic anemias. Um, Chronic diseases, renal failure, anemia of inflammation, hemoglobinopathies, bone marrow disorders, and combined deficiencies would cause normochromic normocytic anemias. So it really depends on your history and physical examination, on what test will you work up the patient. Good day, everyone. I'm Dr. Messina. Today I will be discussing the pathophysiology of anemia of inflammation, or what we call AI, is that inflammation stimulates increase in production of the iron regulatory peptide we call hepcidin by the hepatocytes. Hepcidin binds the iron exporter ferroportin, causing internalization and degradation of both proteins and decreasing the delivery of iron from macrophages to the developing erythrocytes. This impairs erythroid development and may lead to anemia if it's chronic standing. Lastly, we have the hemolytic anemias. The main pathophysiology is increase in RBC destruction, but there are several mechanisms of this destruction. It can either be immune mediated or versus non-immune mediated, corpuscular versus extracorpuscular, intravascular versus extravascular hemolysis. And these are the common tests to diagnose or to work up a patient who have possible hemolytic anemia. Uh, an important basic test would be reticulocyte count, so you would expect it to be high. Then you have a serial hemoglobin or CBC. You have Coombs test, LDH, bilirubin, haptoglobulin, hemosiderin, and hemoglobinuria. So these tests should not be done altogether. It will depend on the history and physical examination of the patient. What you are thinking of the possible cause of hemolysis. These are the findings in the lab workup of hemolytic anemia. You have a high reticulocyte, and if you compute the RPI, it's more than 2. You have high unconjugated bilirubin, okay, because you have increased destruction of your red blood cells, and so you have um, higher level of bilirubin to conjugate from the destruction of the red blood cells. Then we have high lactate dehydrogenase enzyme. Serum haptoglobulin is decreased. There's presence of hemosiderin or hemoglobin molecule in the urine. And these are the special tests for hemolysis. So if you're thinking of hemoglobinopathy such as thalassemia, then you may request for hemoglobin electrophoresis. Okay. So this one to look for if this is alpha or beta thalassemia. If you're thinking of a possible enzymopathy, then you can request for RBC enzymes. Then, if you're thinking of a possible immune-mediated or autoimmune hemolytic anemia, you can request for Coombs test or anti-globulin test, the direct and indirect Coombs test. Then you have cold agglutinin test. If there are spherocytes in the peripheral blood smear, then you may be dealing with spherocytosis. You can request for osmotic fragility. For PNH, you can request for Ham's test or flow cytometry of CD55 and 59. And if this is due to hemolysis from microangiopathic hemolytic anemia, that can be due to DIC, then you can request for clotting profile, PTA, PTT, fibrinogen. So, in summary, we have discussed the approach in diagnosing a patient with anemia. So, you have a thorough history and physical examination, and then coupled with the basic laboratory tests such as the complete blood count, the RBC indices, okay, and then the reticulocyte count, and computation of the RPI. If the RPI is less than 2 or you have a low reticulocyte, and then look at the RBC indices, your MCV, MCH, MCHC, and peripheral blood smear. If the patient has a microcytic hypochromic anemia, and then these are the differential diagnosis. The most common would be iron deficiency and thalassemias. Okay, let's go back. If the RPI is less than 2 or a low reticulocyte count and the PBS and RBC indices showed that this is a macrocytic, normocytic anemia, then you're dealing with megaloblastic or the non-megaloblastic anemia. And if it's normocytic, normochromic, and then these are your differential diagnoses. Okay, if you have a high RPI, high reticulocyte, no, RPI more than 2, then you might be dealing with anemia due to bleeding or blood loss, or anemia due to peripheral destruction of red blood cells, such as the hemolytic anemia. With that, I'd like to thank you all for listening, and I hope that you will remember the important concept in diagnosing anemia. Thank you again.